My name is Kenneth Davis. I, along with my wife Susan, we run the support group out of West Alabama, located in Tuscaloosa, and we've joined with Stuart to help bring these programs throughout the state and look forward to many more. Wanted to let everybody know that our next program in Alabama is going to be on December the 5th, and it's going to be in Mobile, and that will be our first time there. So if you're within driving distance to Mobile, keep us in mind. You'll be getting email blasts and Facebook posts and those type things as reminders, and we look forward maybe to seeing some of y'all down there as well. Well, that's about it for me. At this time, I want to introduce Stu Schlossman, the president and the founder of MS Views and News.
Well, thanks, Ken. So for those that don't know, yes, my name is Stuart Schlossman, and as Ken just told you, I am president and founder of MS Views and News. And this all came about when I was diagnosed. I was diagnosed back in the late 90s, but by 1999, I realized that there just wasn't the information out there for me, and those that I was meeting in support groups were not finding information about multiple sclerosis from what they needed. So from just a very, very small support group, I was finding information on the internet, and I decided to just start sending it to everybody and find what they wanted to learn about to do with their own MS. And where I was sending information out to just 20 people at that time in one little town, well, down in Miami, but now it goes to our information is now reaching people in over 90 countries, and over 30,000 people are now registered to our website. So that's what we're doing for everybody these days. So that's a little bit about MS Views and News. All right, so now you know, you heard also all the programs that we're doing. We've now completed over 170 educational programs since we first started doing this just 5.5 years ago. In addition to that, we now have over 160 videos found on our learning channel on YouTube. Okay, and before I go any further, I want to thank the provider of the funds to do tonight's program. We want to thank Genzyme, a Santa Fe company, for giving us tonight's funds. And I got to thank them. Listen, at every one of our programs are funded by the pharmaceutical industry, and it's very important for you all to know, you all, y'all, whatever you want to hear, okay, all y'all, okay, I got that going too, all right? It's very, very important for you to know that the pharmaceutical industry really wants you to know what is bothering you or what is ailing you or how you can moderate your illness, all right? I don't like to use the word disease. I like to just say your illness. To me, a disease is something that's going to take your life, and this is not going to take your life. You just got to learn to be compliant with your medication and get on medication. If you're not, be compliant, and you'll be a lot better off than not doing one of these medications. So we want you all to learn from everything that is going to be discussed tonight. Tonight, by the way, is our 34th program of this year. Last year we did 40 programs, and at the board meeting at the beginning of this year, I told my board of directors, I said, I'm exhausted still from last year. I said, we cannot do 40 programs again. We got to do 35. Well, by the way, when this year comes to a close, I just told you this is our 34th. I only said I wanted to do 35. When this year comes to a close, we'll have done 45 programs this year. Yeah, all right. It is a lot to do. We only have 52 weeks in the year. So, you know, Ken started saying something about us being in Mobile, Alabama. Well, the idea is we wanted to make Alabama our next big state for MS Views and News. We want to use Alabama more so than any other state in the United States. Why? I have no idea. I just fell in love with this state, all right? And I really want to bring the programs here. So we want to do different types of series of programs in Huntsville, in Birmingham, in Montgomery, in Dothan, in Mobile, and from that, you know, we could probably get everybody from the state to attend one program or another. So this is something that we want you all to know for the future and be able to educate others that you might know with MS, that if they don't know us, it's time for them to get registered and make sure they do know us, so that way we can make sure that everybody is being educated. Tonight's program, again, is being video recorded. You heard that. We're going to go around the room during Q&A, and as Kenneth told you, nobody is going to get video recorded. If you don't want your voice recognized by somebody out there that might be watching the YouTube channel, well, just remember, Florida's right nearby. You could talk like Mickey Mouse. Okay? So do that. Do yourselves a favor. Make sure that you have all your questions written down. If you think of something while one of the speakers is talking and you don't want to forget, write it down, all right? Write on your hand if you need to. And just remember that during Q&A so that way you don't forget what you wanted to ask. Speaking of that, I want to let you all know, on the top of our website, which you can't see right now, but we have a communication tool for you to use with your neurologist. And this was designed by a neurologist and people from our staff, all right? And on there, the communication tool is under the information, I believe. And on there is, when you go to your physician's appointment, patient communication tool, right. So when you go to your oh, that's right. We don't have internet, so you can't see that right now. Okay, so anyway, when you get home, you can look it up. When you go to your neurologist appointment, everything and anything that could possibly be wrong with you and your MS or about your MS will be on that communication tool. You may want to print it off in advance of your appointment, all right? Check off everything that's bothering you. So when you go for your neurology appointment, that you don't go through wherever amount of time that you're in there for and, okay, now time's up and you're getting ready to leave and, oh my gosh, I forgot to ask you about this. And your neurologist or nurse practitioner says, well, I'm sorry, we don't have time. Can you write it down and bring it with you the next time? Or send me an email or contact our office and you get a reply. But if you use this communication tool, you'll have your information all brought with you to your appointment, and you'll make sure that you're going to leave your appointment with everything that you wanted to ask or needed to ask is there. Give it to your caregivers. Let them fill it out as well in case they remember something that your MS memory doesn't remember, okay? All right, so no more of that. Now, every time we come to a new venue, which these days is getting more and more popular, but every time we go to a new venue, we want to ask support group leaders to come on up and speak about 90 seconds about their group. And tonight, we just have one support group leader here, and that will be Craig Snell. And we also have a person here from the National MS Society, Kylle Stambach. Okay, I got that right. And we're going to ask Kylle to come up here as well and speak. And in fact, we're going to ask her first. Come on up, ladies first. All right. By the way, this is something really, really new. We're now like partnering with the MS Society to do a lot of these programs, which is why I want her to speak.
Hello, again, I'm Kylle Stambach with the National Multiple Sclerosis Society. I work out of the Birmingham office, however, we cover Alabama and Mississippi. Thank you. We cover Alabama and Mississippi, so as many of you probably know, here in this area in the spring, we have Walk MS that kicks off right here at the stadium. And coming up this weekend in Birmingham, if anyone wants to drive up, we have an Everyday Matters program which teaches you how to live your best life with MS. And that is going to be at our office, so that's the next thing we have coming up in this area. If you are interested, you can call the 800 number to register or to get more information about the society. The number is 1-800-344-4867 or 1-800-FIGHT-MS. And there's also an information table outside where you can get information about the society, and it has the phone number on it as well.
Thank you.
Thank you.
Thank you. That's the whole idea behind MS Views and News, though, is we wanted to be like a hub for a lot of the information out there. So whatever organization is doing things for people with multiple sclerosis, we want to always invite them to be part of our program. Craig, come on up, please. Thank you.
Well, thank you for all being here, and we are the Montgomery River Region MS group, and they always say that my wife and I, Cindy over here, raise your hand, Cindy, are the leaders of this group. We meet every third Thursday, except in November and December because of the holidays. We'll meet the first week or so of December and have just a big social. But we always eat well, and we always have a good time. So if you want education, you want fellowship, and you want support, come to this group, because you are going to get all three of those, because you will see you're not by yourself, and there's someone there going through the same exact thing. It's different a little bit, but it's the same exact thing. So I'd like to invite you, if you want to talk to me after the program, or any of those people that raise their hand, you can find information out about our group. We meet across the street now from Jackson in the Good Building. If you're familiar with Dr. Epperson, it's his building on the 11th floor. So thank you.
That guy is tall, huh? Wow, I got to, bring this down a long ways here. All right, so without any further ado, I think we should get started on tonight's program. By the way, during the program, you are going to be served. The servers are supposed to start bringing it out at 6:45. I have no idea what time it is, so you can just know that. And please do pay attention as well while you're eating. So, the first one we're going to have is Dr. Emily Reiser, who most of you know from Birmingham. And again, she will be speaking for a little while, and then we'll do Q&A, and we'll go around with the microphones. Watch your step up. And then after Dr. Reiser, we're going to go with our second speaker, and I'll introduce him later on. Thank you.
You're welcome.
You know where to stay, right? In the box.
I've been told to stay in the box, right here. Thank you, Stu. Thank you, Ken. I really appreciate the opportunity to be here. I love this support group. I think by far and away, this is the most fun and great support group, and we have incredible leadership with Craig. So, good evening. My name is Emily Reiser. I'm a neurologist. I've been a practicing neurologist, believe it or not, for almost 30 years. I am married to a neurologist, and I specialize in the multidisciplinary care of patients that have multiple sclerosis. So tonight, Stu has asked me to talk about two topics. The first is therapeutics in MS. I can see you now, Craig and Cindy. The first topic is therapeutics in MS because I think this is really mushroomed, and I think that many of the questions tonight will have a lot to do with this topic. And then the second topic is symptoms management. So I'm kind of teed up to talk for a while, and I'm going to look at your faces, and when I see that you need to stretch or stand or whatever, we will make that happen. And also, you know where the bathrooms are, so at any point in time, if you feel like you need to go to the restrooms, that's perfectly fine. Just exit out the back doors. Okay. So enough about me, but when we look at treatment options in MS, it's pretty daunting now when we think about what all has happened. I am old enough to tell you that when I started neurology in 1985, we had no treatments for multiple sclerosis. All we had was just empirical treatment with chemotherapy, and we had steroids, and those things have been around since the beginning of time. So when we think about treatment for the acute presentation of MS. So someone is going to come to us, the neurologist or the nurse practitioner, after they've had what we call a relapse. And that's going to be a new neurological event that lasts for more than 24 hours that translates into some type of functional impairment. So it's something new, it lasts for more than 24 hours, and it's going to translate into some type of functional impairment. So for relapse management, our strategies are going to surround primarily steroid treatment, whether that be synthetic steroid treatment, kind of a natural pro-hormone steroid approach, and sometimes in extreme cases, something called plasmapheresis. So the gold standard now, based on where we are with the insurance companies and what have you, is a regimen called IV Solumedrol. Any hands up? Anybody ever had that? Okay. It's not that fun, but it is necessary. And it's comprised of a big dose of synthetic steroids, 1,000 milligrams, given intravenously for at least 3 to 5 days. It can cause your blood pressure to go up. It can cause your blood sugar to go up. It can make you have insomnia. Most patients I know that are on steroids are up all night watching Netflix and dusting. That's typically what they do. So, but that's our gold standard, and because of cost, that is our go-to treatment for relapses. After that, if someone has an incomplete response to IV Solumedrol, meaning we gave it and the vision didn't come back or the numbness didn't go away or the weakness is still persistent, then we have the go-ahead to use the next product, which is called Acthar. The other indication besides incomplete response would be if somebody strictly does not have an IV site, because Solumedrol has to be given in the vein, and if someone has no IV access, and Tasha knows this all too well, then we have to fall back to something that we give subcutaneously. And then the third indication for Acthar would be if someone's had a hypersensitivity reaction or a bad reaction to the IV Solumedrol. So if 1 or 2 or 3 of those indications are present, then the insurance companies will let us go to something called Acthar, ACTH, which is the prohormone that comes from our pituitary gland. Now, we don't get it from humans, we go and get it from pigs. So don't order all the pork tonight, okay? Because we need to save a little bit for our Acthar. Because we acquire Acthar from porcine pituitary glands. And because of that process, it's very expensive. And because it's expensive, the insurance companies want to use that second line only when those indications that I discussed are met. And the third thing is for extreme cases called plasmapheresis. This is the individual that's run the table, they've had the solumedrol, they've had the Acthar, the disability is progressing at a rapid rate. We would hospitalize that individual for several days and we would give them a treatment whereby we would just take all the plasma out of their bloodstream, because all the immune elements that are causing the problems with MS are in the plasma. So it's called plasma exchange or plasmapheresis. So that's going to be our strategy for relapse management. But the more daunting part of what I do on a day-to-day basis is trying to pick and choose at that time point what disease-modifying therapy is going to be appropriate for that particular patient. All of you here, as I look out, and I know many of your cases intimately, you're all so different, okay? You can be young, you can be old, you can be Caucasian, you can be African American, you can be a man, you can be a woman. There's a lot of variables at play, and now we have 12 disease-modifying therapies. I would say primarily 11 because we really don't use this thing at the bottom called Novantrone anymore. Here. We used a lot of that back in the day. But if you look, the first FDA-approved MS therapy came to market in 1993. And this is what our timeline looks like. And we're probably going to get another FDA-approved drug probably first part of 2016. So we have really kind of moved at a fairly fast clip from 93 to 2015. And as I stand here before you tonight, I am just joyful about the fact that we have all of these opportunities. So this is the cartoon that there'll be a test on this, and Stu told me if you don't answer all the questions related to this slide, you don't get dinner. But no, this is actually a real representation, you guys, of what we know about MS. If people say, Emily, what is MS? I say MS is an autoimmune disease. It causes inflammation and degeneration of the central nervous system, but really, it's a disease or an illness, as Stu said. We like to use the word illness. It's an illness of the immune system. It is an immune system gone bad. And our immune system is given to us when we are born by our mother, and we acquire this genetically, some from our father. And it's a system that is designed to help us to fight germs and to fight cancer, to thwart off evil things. But for reasons that are very poorly understood, our immune cells, which live out in our bloodstream, they're circulating in our bloodstream, they decide that they don't like something inside of our central nervous system. They don't like proteins in there. And so they basically just squeeze across the blood-brain barrier and they get into the central nervous system, where they then begin to wreak havoc on this green myelin. Not only taking away the green myelin, but also taking away the wire up underneath the myelin called the axon. So this is what happens in this disease. But the interesting thing is now we have an opportunity to target a whole host of sites and cells and things and places to make this condition really dampen down so that you can live a good life with good quality and good functional outcome. So this is the exciting part about what we're doing. But for those of us that are in the space, Tasha, her doctors, Dr. Miller and Dr. Epperson, myself, Dr. Bashir, Dr. Legank, all the doctors you're seeing in the mid-levels, when we see you after we've treated your relapse, this is kind of where we are. Our head's spinning a little bit because we have so many options now, which is fantastic, but we want to be certain that we're picking and choosing things that are appropriate for you. So when I think about MS and I think about treating MS, these are the things that come to mind for me personally. Number one, I want to get your illness under control. That is my primary goal. I want you to feel better. I want you to be able to run. I want you to be able to work out and work and maintain relationships and make money and be happy and do all the things that you want to do. So efficacy is key for me, but I want it to be done in a safe way, because as we go through this, we're going to see that we're going to kind of change the landscape in terms of risks that we accept as we go forward with our treatments. I want you to take this treatment. So if I say take this and you kind of think, I'm not doing a good service to you, because I need to be picking and choosing something for you that you're going to take, something that you're going to tolerate. And then on the back side of this, I'm in contractual relationships with insurance companies. So I have to talk with them on a constant basis about, is this okay for this individual based on their insurance contracts? So they have these things called pharmacy step edits. And so we have to adhere to protocols and policies and procedures to get you what you need so that you get the efficacy and the safety and the best outcome. So Tasha and I, we pull our hair out a lot. My hair's getting gray, hers is not, but that's kind of what we do on the backside. So pregnancy categories are about to go away, and they're in the process of going away, but this comes up all the time. So we do have pregnancy categories, B being the safest, X being not so safe, but we have ways to deal and to work with and to mitigate all of this. None of these therapies bother me. I'm totally comfortable with everything that we use. I use everything on this list. I do not use anything more than anything else. I just try to talk to you, try to figure out, based on your MRI, based on your clinical presentation, who you are, what I think is going to be the best for you. So when we go back to 1993, we had a whole host of injectable therapies that came to market. Our first MS therapy that came to market in 1993 was Betaseron. And on the heels of that, we got other interferons. We got Adherence, we got Rebif. And then there's a funny story, we got Extavia, which is Betaseron. And then we now have Plegridy, which is Adherence and Rebif, but it's packaged up in a way where it lasts a little bit longer so you don't have to inject it as much. So we have interferons, and these are your interferons. So if someone's been on Adherence, I probably wouldn't switch them to Rebif or Plegridy, because Adherence and Rebif and Plegridy are all the same. If someone has been on Betaseron, I wouldn't switch them to Extavia, because Betaseron and Extavia are the same thing. We had a call recently from a patient where her insurance company switched her Betaseron to Extavia, and she was really mad. She says, I want my Betaseron. I was like, well, Extavia is Betaseron, and she didn't believe me. So y'all know tonight that Extavia and Betaseron are the same thing. And there's a story behind it, and if we have time later, you can grab me and I'll tell you the story. And then we have something called glatiramer acetate, and that's Copaxone. And they have a table here tonight, Teva Pharmaceuticals. They're the pharmaceutical company that has brought Copaxone to market. It's an injectable therapy, and we'll discuss that. And so when we look at this cartoon, this is basically how the injectables work. People ask me all the time, what's the deal with these things? I mean, what's going on with these drugs? Why do I have to take all these shots? Well, it's important because when we think about, remember we talked about dysfunction of the immune system, that you have an illness of your immune system whereby your T cells and your B cells are really misguided and misbehaving. We want to change the way that these cells behave. And by using injectable therapies, interferon, for example, we can change what these cells are making, and we can also change these cells from getting across the blood-brain barrier. So the best mechanism of action for interferons is that they change the way lymphocytes behave, and they have a little to do with keeping them in the bloodstream. Okay, not completely, but they have a little to do with that. GA or Copaxone, on the other hand, is an injectable therapy, and it doesn't really work like interferons. It actually changes the way the lymphocytes, what they become. It changes the subpopulations of lymphocytes and actually allows them to go across the blood-brain barrier, where they can then set up what we call bystander suppression inside of the central nervous system. So the mechanisms of actions of interferons and Copaxone are totally different, and that's important for y'all to know. I'm going to briefly run through this because these are very similar, but I think, and it's kind of like I tell patients all the time, if we are speaking the same language, if you and I understand exactly what all this is, it makes our visits so much more productive and so much more effective. So beta interferon is Betaseron is beta interferon 1b, and it is not a mammalian interferon. It's an interferon that comes from a bacteria, from an E. coli bacteria, and that probably has some considerations insofar as its tolerability and how it works relative to the fact that we are mammals. It was FDA approved based on about a 30% reduction in relapses. The dose of Betaseron is 250 micrograms subcutaneous every other day. That's a lot of shots. It does have symptoms that need to be discussed in clinic, and those symptoms are, anybody ever had these? Flu-like symptoms, depression, elevated liver enzymes, thyroid issues, what have you, okay? This is their pen, and every one of the injectable therapies have come to a place where their engineers have created these amazing pens. I can remember a day where we had to draw up everything, and it was really onerous. So we have the option with this to give it in a pen form or also to give it in a pre-filled syringe. Avonex is a Biogen IDEC product. They have several products that have been FDA approved. Avonex is a mammalian interferon. It comes from a Chinese hamster ovary. It's an injection that's given on a weekly basis in the muscle. It was not FDA approved based on its relapse rate reduction. It was FDA approved based on the fact that it did slow the progression of disability. So there's a lot of brouhaha about comparing interferons to interferons, and I would say that that argument is all over. We don't argue about any of this anymore. This is what their pen looks like. And then there's Rebif, which is Avonex. Avonex and Rebif and Plegridy are all the same thing. They're all interferon 1A, and they come from Chinese hamster ovaries. The only difference between Avonex and Rebif is given subcutaneously 3 times a week, either in 22 or 44 microgram doses. They've got a pen. It's got the exact same side effect profile. So if anyone's on Rebif, we wouldn't switch them to Avonex. If anyone's on Avonex, we wouldn't switch them to Rebif, nor would we switch them to Plegridy. It just wouldn't make sense. This is their pen. They have escalating doses to get you to the 44 micrograms 3 times a week. This is Copaxone. Copaxone is a non-interferon, and it's very important to talk about this because it is unique in the way it behaves. It trains lymphocytes to become more, let's say, friendly or gentler lymphocytes that don't gen up as much inflammation inside the central nervous system. This is a sequence of 4 amino acids, which are the building blocks of our proteins. So this is something rather natural. It was FDA approved based on its relapse rate reduction data, and the dose is 2 doses. One, the original dose was 20 milligrams subcutaneous daily, and then they had a different trial called the Gala trial. Well, now they have FDA approval for a double dose 40 milligrams, which can be given 3 times a week. So that's a Monday, Wednesday, Friday proposition, weekends off. The side effects of the GA, which is not an interferon, are different. They can sometimes cause a little bit of atrophy up underneath the skin called lipoatrophy. And then rarely can you have something called an immediate post-reaction after you inject it. It's very rare. Your blood pressure goes up. It makes you feel like you've kind of had a double espresso. It's not dangerous. I get a couple of calls for these every year. This is their pen. Here again, there have been modifications on every pen. Do any of y'all use the pens? Do y'all, hands up, interferons, Copaxone? Okay. All right, oral agents. I think this is where a lot of excitement kind of started to begin. And there was a big, race out there to see who was going to bring their first oral agent to market, and that was Novartis. And they brought a product to market called Gilenya. And these are the chemical names. So these are going to be the names, the trade names on the left, and then the chemical names are going to be the names on the right. And here again, it's all about nomenclature, and it's important to know what these things are. And then if somebody asks you a question, you'll kind of know. So Gilenya is fingolimod, and it's a product that was brought to market by Novartis. Aubagio, I love the name. Teriflunomide is a product brought to market by Genzyme. And then Tecfidera is an oral agent, Dimethylfumarate, that was brought to market by Biogen Idec. And some of these things have been kind of around for a while for other indications in Europe. So now these have been FDA approved as treatments in our space to improve the quality of life for folks that have MS. So Gilenya was FDA approved in December of 2010, and this is a pill that you take once a day. It has a very unique mechanism of action. Remember I talked to you about how interferons keep lymphocytes from making certain things and have a mild effect on trafficking. And I talked about GA, Copaxone, how it actually changes the way the lymphocytes appear and makes them less reactive, and it goes into the blood-brain barrier, across the blood-brain barrier into the brain. This is really different because this drug actually works in the peripheral system. It sequesters or keeps your lymphocytes, and those are your T cells, and your B cells, the ones you get when you're born from your mama, a little bit from your daddy. It keeps these cells inside of your lymph nodes. And by virtue of doing that, then these cells can't move around in the bloodstream, and they cannot therefore find their way into the central nervous system where they can gin up all this inflammation and degeneration. So very unique property, okay? And it works on a receptor called S1P. And when they did their trials, basically it showed a fairly robust impact on relapses. But it does have a side effect because these receptors at the level of the lymph node are also in the myocardium of the heart. So when we go to give Gilenya for the first dose, it could induce what we call bradycardia, which is low heart rate. So that first dose observation has to be done in a doctor's office. So first dose observation with Gilenya has to be done in a doctor's office. And if you're off of it for 2 weeks, you have to circle back around and do it again. So that's very important to know. It's got some other things that we have to monitor. We have to monitor the eye periodically because it can make the macula swell, which is something in the very back part of the eye. It can make the lymphocytes go down, and because of that, there's concern that there could be the emergence of other infections because our lymphocytes are supposed to protect us from things like herpetic infections, tuberculosis, and what have you. But the scary thing that's, I think, come to bear, and I get questions about this all the time, if there have been 3 cases of this thing called PML, and we'll talk about it later, reported in patients that had not had prior exposure to immunosuppression or to Sabri. So we'll get into that. This is the cartoon showing how Gilenya works. Basically, this is the lymph node here, and the lymphocytes are in the lymph node. That's where they're hanging and chilling until they're recruited up to go out into the bloodstream here. And then once they get into the bloodstream, they see something in here that they don't like, so they go from lymph node to bloodstream to brain. So Gilenya keeps them right here, but it comes with that side effect profile that we discussed. Aubagio. Aubagio is an oral agent, and we talked about it being brought to market by Genzyme. It has a big old name called teriflunomide, and it's very interesting because teriflunomide has probably been tested in more MS patients than any agent that we have. They have several large trials where they've looked at this relative to relapse rate reduction and what have you, and it turns out that it probably has a really, really good impact on disability because in these trials, the patients that they tested had had MS for quite some time. But it's a once-a-day pill. It has a very unique mechanism of action. It has something to do with preventing something called pyrimidine synthesis. And our lymphocytes, just like in the morning we have to have our Wheaties to get us going, we have to have our Wheaties. Well, these lymphocytes have to have their pyrimidine. And without it, then, they're not gonna be able to function. So this is gonna prevent pyrimidine synthesis, and it's gonna have an impact on all those really bad lymphocytes. So that's how this works. It comes in 2 doses, a 7 and a 14 milligrams. It's not necessary that you start on the low dose. The 14 milligram is actually the more impactful dose. but for some reason, some people get scared and think they have to start on 7, but you really don't. It has a warning on it relative to pregnancy, and here again, some of those things are going to be changed by the FDA. But it also has a warning about the liver because it has a kind of a mother drug that ginned up some liver issues. So because of that, we have to check the liver enzymes every month for 6 months. I've not seen any problems so far, and it's just something, as long as we manage these risks, we can mitigate these risks. We monitor for liver enzymes every month for 6 months. If for some reason that drug has to be stopped, the other thing that can be done is there's something called a rapid elimination. It can be taken out of your system very quickly by either taking charcoal or something called cholestyramine. So that's how it works. Tecfidera. This is Biogen IDEX product. They have Adherence, and now they have Tecfidera. And they'll have another drug I'll talk about too in just a minute. But it's an oral medication. Gilenia's once a day, Tecfidera's once a day. Gilenia's once a day, Aubagio's once a day, but Tecfidera is twice a day. Twice a day. So when I'm talking with you and thinking about efficacy and adherence to therapy and safety and what have you, this is twice a day. This is twice a day. So, and I know folks that take antibiotics take about 3 days worth and then they put the rest of them in the medicine cabinet. We're just human in that way. But this is twice a day and we have to think about it. So it's an immunomodulator, but an immunosuppressive to some degree. It reduces relapses. That's kind of how it came to market in the clinical trial. It's 240 milligrams twice a day. And yes, it will make you flush. Girls, those of you that have had hot flashes, it's a little bit worse than that. It goes away. It is mitigated by taking a real fatty food, like taking it with milk, peanut butter, something like that. So you really don't want to take it on an empty stomach. It can also cause your lymphocyte counts to go down. And I think this has been a story that's been unfolding here recently. What are our lymphocytes? What are our lymphocytes? Our T cells, our B cells, our immune cells. Those are the cells that we're trying to keep under control. They're ginning out of control, so we definitely want to get them under control. And we can accept some degree of lowering of the lymphocyte, but we have to be very mindful about that lymphocyte count getting too low, because now they have had 2 cases of this thing called PML reported here stateside. Okay, so BG12, best mechanism of action, I'm not going to bore you with the details, but it has an impact on something called NRF2. NRF2 is a very important, it's called a transcription factor, but basically it's a protein that really helps to maintain antioxidants. And everybody's into antioxidants, and so we like antioxidants. So we think that BG12 or Tecfidera works by virtue of keeping oxidative stress in lymphocytes under control. So that brings me to our final discussion of something that I think that is very, very, very interesting. I think that what we're going to see as we move forward in this space, we're going to see more drugs that are in this class. And this thing is called a monoclonal antibody. A monoclonal antibody. So you notice that I put in there in caps, in parentheses, MAB, MAB. So every drug that you see, if it ends in MAB, it is a monoclonal antibody. That's the take-home message about this part of the talk. So these MABs, or these monoclonal antibodies, are scientifically engineered in the lab to do something very specific in the nervous system. And remember we talked about that first cartoon, and I told you there's going to be a test on it, and Stu said everybody had to pass it to get dinner. Well, remember, we had so many places in that cartoon where we could have an impact on the immune system. Well, the scientists designed these MABs to specifically do things where they want it to be done. And they do it by pre-treating a little mouse with a specific protein and then combining that with a human cell to create an endless supply of monoclonal antibodies. So here's our friend. There he is, Fred, and he's just chilling down there in the lab at UAB with my friend Tara. And she's thinking to herself, I want Fred to, couple up his antibodies with some of my human antibodies over here, and we're going to make an endless supply of this thing called MAB, or monoclonal antibody. So basically, we inject Fred, and Fred will produce B cells, what we call plasma cells, and these plasma cells will create antibodies, and antibodies are good. We like our antibodies, they fight things. And then we'll couple this murine or mouse cell with a humanized tumor cell, and then we'll create something called a hybrinoma. And because it was genetically programmed to do something specific, then we have it. We can just create as much of this as we need in a pipeline. So this here is actually what we call the lymphocyte. So this could be the T cell or the B cell. And the way our T cells and our B cells work is our T cells and our B cells are expressing things on their surfaces. And these things that are being expressed are called classification determinants, or CDs. Not like the CD that you put in that spins around, but the CD that's on the lymphocyte. So these CDs have numbers. They can be CD20, CD25, CD52. They can be all kinds of things. And in the case of what we're trying to do with monoclonal antibodies is we're trying to create them to do something specific. So here is an antibody. It's a monoclonal antibody, and it's hooking on to something on that lymphocyte. And it's going to change the way that that lymphocyte either behaves or what it does or how it moves or changes what it does in the system. So the FDA has approved 2 monoclonal antibodies. We have 2 monoclonal antibodies that are FDA approved. The first one is natalizumab. Any guesses as to what that drug is? There'll be a door prize. Maybe. Now, does anybody know what natalizumab is? Tysabri. Okay? Light bulbs just went off. I just saw it. Okay, so natalizumab, what does it end in? MAB. Natalizumab. That's Tysabri. And so it has a scientifically, genetically engineered effect on something called alpha-4 integrin that is being expressed on the surface of a lymphocyte. And so if we can make a monoclonal antibody to alpha-4 integrin, then we can specifically block that lymphocyte from going across the blood-brain barrier. The second one that's FDA approved is alemtuzumab. Alemtuzumab is this one. And what is alemtuzumab? It was just FDA approved. I didn't put the names up here because I thought it'd be kind of fun. Lemtrada, I just heard it. Okay, so natalizumab is Tysabri, and alemtuzumab is Lemtrada. And Lemtrada was genetically and scientifically engineered to latch on to the CD, the classification determinant 52. And those are on lymphocytes, T cells and B cells, and by virtue of binding up with that, it can have an impact on those cells. Now, these are emerging or off-label MABs, and you can see the list of them. There is a drug here called rituximab. There is a drug here called duclizumab, and there's a drug here called ocrelizumab. And these MABs are getting hard to pronounce, harder and harder. But there's a gazillion of them in the pipeline, up to and including MABs that will restore, perhaps, or help to restore myelin. So this is where the MAB story is going. So it's pretty fascinating. So this is, now you see the name, Tysabri natalizumab. It was the first monoclonal antibody FDA approved for patients with multiple sclerosis and Crohn's disease. And I have several patients that have multiple sclerosis and Crohn's disease. They have both. So it's a good treatment for that cohort. But it's a standalone for MS based on its data. It reduces relapses by 68%. It is an intravenous treatment. It's given for 1 hour. And if you want to know more about the process, you can talk to Tasha. She is an infusion nurse specialist here in Montgomery who infuses this monoclonal antibody. And she's quite savvy about everything that goes along with it. It's a 1 hour infusion and a 1 hour observation. It does have a black box warning, and that's a big thing when the FDA gives a drug a black box warning, because it has unmasked hundreds of cases of this thing called PML, progressive multifocal leukoencephalopathy, aka PML. It's a lot easier to pronounce. But PML is caused by a virus that we acquire when we're children. So when mama's kissing on us and daddy's hugging us, they can possibly give us something called a JC virus. It's kind of like chickenpox or something. It's really benign, but half of us acquire this from our parents when we're babies, and half of us do not acquire this from our parents when we're babies. When we become adults, some of us can be exposed to this, very low percentage, but it can happen. But when this virus is left unchecked in our bodies, and it finds its way into the central nervous system, it migrates from the bone marrow and the B cells in our kidneys, and it migrates into the brain. If we're giving a drug, Tysabri, that blocks trafficking of lymphocytes across the blood-brain barrier, and theoretically the virus gets into our brain, then the necessary lymphocytes that we need to get rid of the virus can't get to where they need to be, and this thing called PML can emerge. So that's the story behind PML. And it's now been reported with 2 of the oral agents, as we mentioned. So this is what PML looks like. This is an axial MRI scan in a patient that has PML, and it's called progressive multifocal leukoencephalopathy because it's multiple lesions. They're really big. They're not like the little skinny oval lesions that we see in multiple sclerosis. These are big, gnarly lesions that we see. In the case of Tysabri, if we suspect it, we can prove it through spinal fluid. If we prove it, then we have to go and take the patients to the hospital and do the plasmapheresis, which was that first thing I talked to you about for extreme relapses. We use that in the case of natalizumab to get rid of it in hopes of allowing the brain to die back down. So this is Tysabri, that's a vial of it, and it's given over a 1-hour infusion. It works by virtue of latching on to this thing. It's a monoclonal antibody. This is your lymphocyte. This little thing here called VLA or alpha-4 integrin has to bind with this thing on the blood-brain barrier, and by virtue of blocking that with that little bitty monoclonal antibody, you can prevent this lymphocyte from binding onto this ligand, and then that cell can't get into the central nervous system. So it's a monoclonal antibody, an MAB, that selectively blocks alpha-4 integrin, thereby preventing all of those reactive cells from getting into the central nervous system. This is Lemtrada, and a lot of folks from Genzyme are here tonight, and I know that if you have questions, they would love to field your questions about Lemtrada. So alemtuzumab, so it's a monoclonal antibody, and now you know that its name is Lemtrada, and someone over here knew that. Was that you, Craig? Craig gets the door prize. Okay, but Lemtrada has been around for a long time for the treatment of other diseases in the oncology space. It used to have a name called Campath, but now it's been tested and it's called Lemtrada, has a new name, alemtuzumab. So it's a monoclonal antibody, and it's scientifically directed towards CD52, and these classification determinants are on B cells and they're on T cells. And so what we're going to do is we're going to give this for 5 days, and then we're going to wait a whole year. You won't take anything, and then we're going to come back the second year, and we're going to give it for 3 days. So 5 days, 3 days. It's going to really have a big impact on those bad cells, cause them to lyse. Some people feel bad when they get this at first, but there's a whole protocol for monitoring and managing this. It has a very robust impact on all of these things, relapses, MRI, disability, and what have you. But it has some side effects. Remember, there's a yin and a yang to everything. Everything has a side effect. But like I said with my opening remarks, none of this scares me. I know how to mitigate risk. I know how to work with you. We work together to make certain that we get the efficacy and the safety and the adherence and the compliance that we're looking for. So we have to monitor the blood work on Lemtrada every month for 60 months. We know that in about 30% of the times it's going to have an impact on the thyroid, either hypo or hyperthyroidism, kind of unmask an autoimmune thyroid disease. Rarely it can affect the platelets, which are the sticky elements of the blood. Rarely it could impact the kidney causing an autoimmune thing called good pastures. It might rarely be responsible for unmasking things, opportunistic infections, malignancies, what have you. We have to measure and monitor for melanoma and all these things with all of these drugs. So none of it scares me, but this is fascinating because of its impact on disability and those other metrics that we talked about. So this is what Lemtrada looks like. I think the most active site in Alabama right now for Lemtrada is the site in Coleman. And I've actually sent several patients there because the doctor, Dr. Legank, who many of you may know, he was actually part of the clinical trials that helped to bring Lemtrada to market. So I feel like he really has a wealth of knowledge and experience with the Lemtrada. So I've been working and collaborating with him with Lemtrada. Lemtrada is an anti-CD52. So if you see that yellow thing, what is that? A monoclonal antibody attaching onto a classification determinant called anti-CD52. So that's pretty much the mechanism of action. But the fascinating thing, when you look out 3 years, they did 2 trials, CARE 1 and CARE 2. You see these very robust numbers in terms of relapse rate reduction, impact on disability, people not taking DMTs, and so on and so forth. I'm not saying that that this is the end all for everyone, but I'm saying for certain cases, for certain forms of MS, this might be a very good selection, okay? I can't help but go over this because we can't have a discussion about this illness without talking about the cost of managing and mitigating this condition. Many of you have been strapped with high deductibles. Many of you have lost your jobs. Many of you have no resources. I understand that. And that's why we work to get out here to promote awareness and to promote education, working with Stu, working with Kylle, working with all of our resources, working with pharma. The folks back here at this table, they just do a lion's share of really working with our clients to get them free drug and helping us to get copay assistance. And thank you so much for all of the good work that you guys do. But I think that we do have to be mindful of the fact that, when many of these drugs were approved, they were a lot cheaper than they are now. And we're looking at, cost interferons up in the 60s, natalizumab in the 60s, fingolimod in the 60s, Aubagio in the high 50s. So we need to talk with our policymakers and we need to be engaged in this conversation because these are game changers. These drugs have given you back your life, and we together, Tasha, myself, clinicians, working with you, the constituent, the patient, we want to see to it that you get what it is that you need. So I'm going to end with one slide that I think sums it up for me in the therapeutic space, and it's this slide. A lot has happened since 1985. I was there. I know what this used to look like, and I don't see anybody in this room that looks like what we used to see in 1985. There have been extraordinary gains and discoveries in this space. That's why I go to work every day. I love what I do, and it's because of this. It's because our great scientists and working through pharma and working with the NIH, they brought us all of this. And it's not cheap. And it's a very difficult process to bring a drug to market, but this is what we have. We now have injectable therapies, oral therapies, and monoclonal antibodies. When we look at efficacy, sure, we look at things like monoclonal antibodies perhaps having the greatest efficacy, but they do come with some degree of risk, and we have to understand that. And then we look at old drugs tried and true, like the injectables, that are extremely safe, and for certain clients, they're so effective. So we have all of this now kind of swirling around in front of us. But I think as you go away tonight, I want you to at least understand kind of what all these things are, kind of what space they're in. Is this an injectable therapy? Is this an oral therapy? Is this a monoclonal antibody? Is this what I'm after? Is this what I'm after? Am I over here? Do I need to be up here? And these are the conversations that you need to be having with your healthcare providers, okay? So that's the last thing I'm going to say about the therapeutic space, and then we'll segue into the symptoms. Are y'all eating? Is it good? It looks really good. Questions? Should I take a question now or wait?
No, wait on that.
Okay.
If you could do this like 15 minutes of symptom management,
Yep.
get right into the question.
All right, we're going to just roll right through it. So it looks really delicious. So that's where we are in the therapeutic space. Like I say, it's pretty, really exciting. So symptoms management, when I talk about MS, I think the thing that we need to realize that MS comes in several, it comes in waves. It comes in waves of relapses, yes. It comes in waves of pseudo-relapses, which are when you kind of think you're having a relapse, but it's not. And then it comes in waves of symptoms. Relapses, pseudo-relapses, and symptoms. I would say the bulk of everything on that list that you're going to put down when you come to see me, that Stu's giving you that list, is going to have to do with symptoms. It's the tip of the iceberg. But oh, you look so good. And that's what everyone's frustrated about, because everybody says you look so good. And they think that you're supposed to work 100 hours a week, and they think that you're supposed to do everything and multitask and run around and be in charge of the PTA and do everything. Well, up underneath all of this, you've got bowel and bladder issues, you've got cognitive issues, you've got fatigue, you've got depression, you've got pain, you've got this, you've got that. This list goes on and on and on. So these are the more common MS symptoms that I see and treat in my clinic. And I think fatigue is probably at the top. Visual symptoms, pain, cognition, bowel, bladder, paroxysmal symptoms, and spasticity. So just a few. Fatigue and MS, show of hands, 90%. It says 80, but I think it's 90. I think it's 100%, I'll be honest with you. And I don't think we've done a good job of really drilling down on this, but it's kind of like this lack of energy, this lassitude, this cognitive like fatigue, like I can't function kind of fatigue. This isn't like just waking up after a bad night or something. This is something really serious. You can't get out of the bed. You can't really get out of the house. It probably is more prominent with people that have some degree of brain atrophy. We always need to exclude other things like depression, medication side effects, insomnia, treat sleep-related disorders. But when you think about MS and you think about fatigue, there's all these other things that are kind of swirling around it. So it's not always easy just to treat it because, you know, there can be sleep-related issues, there can be mood-related issues, there can be stress-related issues, there can be money-related issues, there can be a whole host of things that are exacerbating fatigue. So we want to determine, is fatigue related to the MS, or is the fatigue related to something secondary like, you know, they're taking medications like that are making them sleepy or feeling kind of weird. But at the focus of our treatment is energy conservation. I tell people this all the time. You've just got to get back on a schedule. And you can't be spinning your wheels all the time and running around with your hair on fire. You got to slow it down a little bit. The energy conservation is one of the keys to success when managing fatigue. And then everything else we have, you guys, is off-label. So we have the narcolepsy drugs, which are which are Nuvigil and Provigil. The insurance companies cannot stand to pay for these things. We love these things, but we have to do PAs to get these. And then we have old school stimulants. That's going to be Ritalin, Adderall, Dexedrine, and all of those things. Has to be put on blue paper. You got to go to your doctor's office to pick it up, but they do work off-label. Visual symptoms, very common in MS. The most common relapse that we see is probably optic neuritis. That's how people come to me. But after that, people can have residual loss of acuity, and that can impact the workplace or what they do in terms of driving or what have you. They can have color desaturation, particularly for reds and greens. So all the Christmas colors seem to be affected after optic neuritis. And then there's this very interesting phenomenon. It's called UHTHOFF, UTOFs, named after a German doctor that described it. But this is when someone goes outside and it's really hot, or they've run a marathon, and suddenly they get blurred vision. It's very transient. If they go back inside, drink some water, chill out, put their feet up, it'll go away. It's an UTOFs phenomenon. It is not a relapse. And then it's also important to have an ophthalmologist on the team. Everyone with MS needs to get their eyes checked on an annual basis. It's very important. Pain in MS, I would say 90% of patients have it. When I started neurology in 1985, there was this old adage that no one with MS had pain. And they used to think that people complaining of pain were just kind of hysterical or something. But show of hands, how many people with MS have pain? Yes, it's very significant. And this is something really squirrely. It's not like, kind of like my shoulder hurts. It's like can be hot, it can be piercing, it can be kind of gnawing, it can be aggravating, it can be everything. And the pain can be in one distribution, multiple distributions, it can fluctuate, it can change at a moment's notice. There's no rhyme nor reason to this pain. So our approach is a multidisciplinary approach using a whole team of folks, up to and including pain management if necessary. We do use analgesics. We like to start out with the ones that aren't habit forming. We sometimes have to segue into opiates if necessary, long-acting opiates, anti-epileptic drugs, Trileptal, Tegretol, Keppra, and in some cases Botox that can even help in certain pain pathways. Cognitive issues in MS, totally underestimated. Leading cause of bringing people out of the workforce. And I would suggest to anyone that's newly diagnosed, it's very important to get your cognition assessed, because remember, I told you, oh, you look so good. When your case comes up before the judge, if you're trying to get Social Security disability, which we're going to talk about in a bit, or disability through a short-term or a long-term plan, if you don't have this data documented, you're probably not going to get your disability. So it's very important early on in the journey to get this cognitive data documented. And we do that using an assessment called BICAMS, and it's a bunch of tests for memory and processing and so on and so forth. We think that, that the primary problem here is probably some changes in the white matter as well as the gray matter. We now know that MS is both a white matter and a gray matter disease, and newer studies are correlating some of this cognitive stuff with brain atrophy. We don't have specific treatments, but we do use off-label drugs. I've talked a lot about off-label, and we need to do a better job of testing and bringing other things to market that we can get FDA approved for this. But suffice it to say, right now we're using some of the Alzheimer's drugs like Aricept and Namenda and some of these off-label. This is actual brain scans of patients with MS. Healthy control is A patient with relapsing MS is B, and a patient with progressive MS is C. And what we see, like I talked to you about, is this is not just a white matter disease, but over time, the gray matter, which is the outside of the brain, can actually undergo some shrinkage. And that's why we really want to get after this early. We really want to get on effective therapies, and we want to impact this as soon as we can. Mood-related disorders, yes. And these include depression, anxiety. There's a slighter increased risk of bipolar in patients that have MS. A really interesting phenomenon called pseudobulbar affect, and this is where an individual might laugh or cry inappropriately. They might come to see me and I say, how you doing? Ah! So pseudobulbar affect, it's a real condition. It can be very embarrassing, very debilitating, but we do have treatments for it. The treatments for anxiety and depression are our tried and true antidepressant medications, our SSRIs, tricyclics, a whole combination of things like that. But this thing at the bottom called Nuedexta is actually FDA approved for pseudobulbar affect. So the PBA stands for pseudobulbar affect, the inappropriate laughing and crying, and we have a strategy now for treating that. So on to ambulation. Ambulation is very interesting because many things are at play as it pertains to our walking. And when I diagnose someone with MS, I think the thing that scares the patient the most, and y'all can correct me if I'm wrong, they worry that they're not going to be able to walk. Yes, they worry that, y'all worry, we worry, us together, that this mobility is going to be affected in some way. So this whole ambulation piece is very interesting. And in many patients, up to about 80% of folks with MS, whether it's even in mild phases or even in more progressive phases, can have some impact on ambulation, walking. And so we like to have our PTs assess clients as soon as possible to assess motor strength, to assess symmetry of strength, to look for any gait deviations, to assess for spasticity, so that we can formulate a plan that can absolutely increase functional outcome, whether that's with or without adaptive bracing devices, what have you, to enhance performance. So, and then there's a medication that's actually FDA approved that improves the speed of walking, and it's called Ampyra, A-M-P-Y-R-A, and it's at the bottom. Here it is. So we can't have a discussion about MS and walking without talking about Ampyra. It is not a drug that's specifically designed to treat MS. It is a drug that's designed to improve the speed of walking. So that's Ampera, and basically it works by blocking potassium channels. You have to have the movement of salt and potassium to have an action potential, and it works by virtue of blocking that. So Ampera is designed for people to improve the speed of walking. You have to have an EDS score of like 2.5 to 6.5. A 2 is you're mild, a 6.5 is you're on a walker. And if you have that, and you are taking a disease-modifying therapy, you could possibly get approved for Ampera. Tasha will tell you, if you are not on a DMT, if you're not on a disease-modifying therapy, probably you're not. Blue Cross is not going to give you Ampera. So you have to be on one of the disease-modifying therapies to get Ampera. And finally, a whole host of things, bladder and bowel. With the bladder, either you don't empty, you empty too much, you have some combination of that. Always see a urologist. We have great urologists here in the Montgomery area. It's important to get that bladder under control. And then bowel problems, traditionally it's going to be constipation. So it comes down to fluids, fiber, Miralax, sometimes suppositories, and in extreme cases, a gastroenterology consult. Sexual dysfunction MS, nobody talks to me about this, but I talk to you about this. It's important to discuss at your clinics. It can be primary based on the disease. It can be secondary based on medications. The antidepressants of the SSRI class, Zoloft, Prozac, Paxil, they have a huge impact on this. And then it can be tertiary based on spasticity and what have you. So paroxysmal symptoms, and I'm about to wrap it up. These are the most interesting things I see. These are those weird neurological things that just occur, without any warning. It can make you kind of draw up like you're having a seizure. It can make your face have really severe pain, like over the cheek or over the jaw. These things come in waves. They're very incapacitating. But fortunately, when we use the anti-epileptic drugs off-label, the drugs like Valium and even something called Diamox, it can actually help with this. Ataxia, there's nothing that treats ataxia. I'm sorry to tell you that. We have been knocking our head up against the wall with ataxia, and I think the best strategy for ataxia is rehabilitation. Spasticity, many patients with MS have this tightness or stiffness or inability to relax. We've got great drugs for spasticity, baclofen, Xanaflex. In extreme cases, you have to go have a pump put in. It's called an intrathecal pump, and it looks like this. So basically, we would go and have a surgeon take a catheter and put the catheter into the intrathecal space. We would connect that catheter to a little hockey puck. We'd place that hockey puck up under the skin, and then we'd use an external device to monitor it, and we can deliver a specified amount of an antispastic drug called baclofen to make you less spastic. So at the end of the day, how do you treat all of this? You treat it with a team. Because if you don't, this thing's going to spiral out of control and you're going to have more complications. So in conclusions, I think, the therapeutic space is fascinating. The symptomatic space is the reality of this condition. You need to stay organized. Like Stu said, when you come to see the doctor, write all of these things down so we can address them and improve your quality of life. We want to strategize together. You need to create a team for yourself. I think that so much of what goes on is beyond just what the neurologist can do. You need, at a minimum, a PT, an OT, a speech therapist, a personal trainer, a urologist, an ophthalmologist. You need MS News and Views. You need the MS Society. You need every resource you can get your hands on. And with that said, that's how you're going to really get the best outcome in this illness. So, sir, I'm here to take questions, and I appreciate your time.
Thank you, thank
You're
you,
welcome.
thank you. I keep seeing your hand in your pocket. Are you as cold as I am in this room?
Those of you that
gosh.
know me, I'm always so cold. That's why I wore something long
I'm
sleeve
not
tonight.
that far away from South Florida, am I? It is cold up here. All right, who's got the first question? Don't be bashful. I know you have.
Never.
Thank you.
Heather.
You didn't talk about athletes in MS
Yeah.
and how important it is to exercise.
It is.
And I have a mobility issue, but I run.
Do you mind coming here with me? Okay, because I think pictures are worth 1,000 words. Okay, so just tell everybody who you are. I know who you are. Just tell your name. Okay. Huh? Okay. All right, do you agree to be on here? Because what she has is a device called yours is the BioNess. Okay. And it's a device, it's called the BioNess, and this is a marathon runner. This is someone that never gives up, that goes out there and runs 13.1, 26.2?
No, 19.3.
19.3. And she does it with a device that actually can take away weakness at the ankle. It's called a BioNess. What do you think about it?
I love it. The insurance company doesn't like it.
How much do they cost?
$7,000.
$7,000. And how do you go about getting a BioNess?
You.
Me. So the doctors have to put in, an order for it, but the insurance companies don't cover it.
That's the L300.
Yeah. It's the L300.
The VA covers it.
The VA
and so
will
does the Air Force.
The VA and the Air Force cover it. The most important thing about this adaptive equipment, though, is it improves the quality of gait. And so, therefore, you can continue to run long distance. And the other thing that we know scientifically is now that runners and high-performance athletes actually have an increase in something called BDNF. It's a chemical in their brain, and it actually enhances neural networks and plasticity. So this is a fascinating story. So for you to share it is, I think, very motivating for the group. Yeah. Keep running.
Great. Thank
Okay.
you. Listen, before we continue with these questions, please know that I or Ken must be with the microphone in front of your mouth before we want you to say anything, all right? Don't be bashful. Just pretend it's an ice cream cone and wait till we get to you.
Yes. Any questions? Oh, good question.
Right here.
Yeah.
My question is about the medication and insurance. It seems like it's driven by insurance on what you can get on first.
Yes.
Doctors are at these insurance companies making these decisions on the steps that you have to take before you start a person on this or that type of drug.
So the question has to do with what we call formulary step edits. And that's the lingo or the nomenclature, so a step edit. So many of the insurance companies are controlled by managers, and these managers are called pharmacy benefit managers. The PBM is what they are. And in the state of Alabama, Prime Therapeutics is a big PBM for many of the drugs that we need together. So their committees that are structured and run by PharmDs, these are doctors trained in pharmacy, look at the literature and look at the data, and then they come to some conclusions about what they think they will or won't pay for. Remember, some of the drugs are kind of alike, right? Like you have beta interferon 1A, you have Avonex, Rebif, and Plegridy. That's all beta interferon 1A, and they may decide, for example, we're only going to put one of those products on our step edit. And then you have glutathione acetate, which is Copaxone, which is standalone. It's probably going to be on everyone's formulary because it's unique. And then you get into the orals, and they're probably only going to pick and choose one oral. They're not probably out of the gate. Now, if you fail an injectable or you fail their one oral, then they'll let you go to the next level to get the whatever else you might need, whether that be a second injectable, lookalike, or two of the other orals. And now we have a new policy written in Alabama for monoclonals. You have to fail 2 drugs to go on a monoclonal. So you would have to fail an injectable and an oral, or 2 injectables or 2 orals to go to a monoclonal. The only caveat being if your MRI shows 2 active lesions where they put the contrast in and it lights up, there's a small pathway that Prime Therapeutics will allow us to use a monoclonal antibody out of the gate. But more than likely, we're going to be dealing with these step edits as we go forward. So our job is to stay plugged in, working as activists through the MS Society, through, educational program, whatever, to get to the people that can affect change and affect policy. We're just here trying to do the best that we can do, right? Together, trying to pick and choose drugs based on efficacy, safety, compliance, what have you. But at the end of the day, it's the policymakers that affect change. So we just have to stay plugged in with them. Yep. Yes.
I was just wondering, how long can MS be in a person's body before it actually rears its ugly head?
Okay, that's a great question. I mean, I love the metaphor. So, I mean, how long can you have MS before it's clinically diagnosed or radiographically diagnosed, shall we say? Clinical diagnosis, radiographic diagnosis, meaning we see it on the MRI. So, by and large, by the time someone comes to us, they've had it a while. And many patients that I see have had MS for years. I've seen people that have had it for decades. But it got misdiagnosed because someone wasn't thinking about it. I see a lot of people that show up in emergency rooms with left-sided or right-sided weakness that are told that they've had strokes. There's pediatric MS. Children can have MS. People over the age of 50 can have MS. So this can be there ginning up activity long before the first clinical event, number one. Number two, we're beginning to see a whole cachet of people showing up in our clinics that have gone to the emergency room because they were in a car wreck. And they got an MRI scan of the brain because they had a closed head injury. And what does the MRI of the brain show? It shows multiple classic MS lesions, and some of them are actually enhancing. So they didn't even know they had MS. They weren't having any symptoms. They had a car wreck. So now we have this thing called radiographic isolated syndrome. So people are presenting to us with MRI metrics showing us that they actually have this. And that, I guess that's good in the sense that we can get after it before it even becomes problematic clinically. It's fascinating. It's a great question. But as soon as we know about it, it's time we should treat it. Because, like I told you, in 1985, we didn't have any treatments, and I know what this, I'm old now. I know what that used to look like, and y'all don't look like that. That's what's so great about this. So the sooner we embrace therapy, the sooner we change the natural history of the disease, and that's true. Yes. Okay.
Next question, over here.
My question is, what can you do about the loss of memory that you have?
Okay, and hello.
Hey.
What can you do about the loss of memory? Remember we talked about the cognitive piece maybe being the most underestimated piece in multiple sclerosis, and it is. So we want to do an assessment early in the course of the illness to determine kind of what's going on. And typically it's going to be this. It's going to be short-term memory loss, speed of processing, retrieval, translating into an inability to multitask. That's what this is going to look like. This is not Alzheimer's disease. This is not a neurodegenerative Alzheimer's thing. This is the cognitive impairment associated with multiple sclerosis. And it can be managed, through cognitive remediation, through using some of these off-label medications, through strategies, energy conservation, whatever. So there's a whole host of things that can be applied to it. But at the end of the day, we do know that if it reaches a certain threshold, it may need the ultimate accommodation, which could be short-term, long-term disability, or something like that. And it is the number one thing that brings people out of the workplace.
Any other questions?
One over here.
Oh, there you go.
Yep.
What about silent progression of MS, where you go in and you have another lesion, but you don't seem to have too many other changes?
That's a big area that we focus on, all of us that are in this space. So what we're constantly looking for is this thing called suboptimal response to therapy or the silent burden of disease. So the suboptimal response, we can see pretty clearly if someone's having relapses, right? But on the MRI, we can see the suboptimal response if we inject the contrast and we see, active lesions on the MRI. But then there's this whole group of people that actually feel okay, that we see more lesions, or the lesions are getting larger, and or they're taking up the contrast. And so in those cases, whatever we're doing is not working. So the consensus now in our space is that we should do images at the time of diagnosis because it's the best thing we have to diagnose MS. We should circle back around after we initiate a disease-modifying therapy to assess whether that therapy is working. And then we should do an MRI on an annual basis because it's going to pick up that exact thing that you've asked the question about. And I think the neurologist or the folks in the field that don't do that, they're really missing out on an opportunity to keep this under control. Because once it reaches a threshold, it crosses over and you can't quite bring that back. We don't have strategies to bring that back. So the annual surveillance MRIs become very important for us. And then seeing our patients routinely every 4 to 6 months. If we see someone every year, that's just not enough. Things happen within a year. Yep. Hello.
Hi. Generally speaking, there's a lot of different illnesses that either by genealogy or by age, there's tests that insurance will start to cover. At a certain age, you can start getting cancer screenings. At a certain age, you might be able to get different genealogical screenings for different illnesses. Is there any kind of big push, or would it be beneficial to get something like an MRI added to that, where once every 3 years you can have an MRI just to see if you've got an illness like MS that doesn't necessarily show up but could start being treated early on?
I think it's a great question. I think if it did come to fruition, it would probably just be in the MS space where maybe a parent, or a sibling or a twin had the condition, But I don't see a day where the insurance company is just going to let us, just do screening because of the cost of it. But the question comes up all the time, just along these lines from parents. They want to know, when do we screen our children? This question comes up all the time. The incidence of that being passed on is low, maybe 3% or so, because even with identical twins, there's only about a 35% concordance rate. So obviously something genomically is fine at play, but something in the environment, something else is unmasking this condition in that susceptible host. So I doubt across the board, but maybe if there's some connection to MS, maybe we might see that. Here again, that's where advocacy comes in and education and all the things that we're doing, like tonight.
Thank you, Dr. Reiser.
Yeah. Is that it? Thank you.
Yes, we're going to end that session now because it's getting late. We got another speaker. Thank you. Thank you very much. By the way, after our next speaker, we're going to have a little raffle as well. So hopefully you'll be around for that. Say that again? Oh, good. All right, so our next speaker, for all that you don't know about, is Kylle McKinney. He's the Social Security Public Affairs Specialist for the state of Alabama. He has been with the agency for the past 24 years, starting off as a claims representative and later being promoted to his current position for the past 7 years. Kylle has a Bachelor of Arts degree in radio television for Alabama State University, a Master of Divinity degree in church ministry, and a doctorate degree in pastoral and Christian care, both from the Minnesota Graduate School of Theology. He's got a lot more to say, too, but I'm not going to keep on talking. Let's welcome Kylle to our program tonight.
Thank you very much, Mr. Schlossman.
Do me a favor, don't touch down here.
Okay, yes, I was giving that instruction. I want to thank Mr. Schlossman for the opportunity, and I want to also say Dr. Reiser did a wonderful job with the presentation. I hope she doesn't give me a test because I know my grade is already with that. But my job tonight is to talk with you about Social Security disability and how that works for you. When it comes to Social Security disability, making sure this clicker, here we go. There are various types of disability programs that we pay. One, we pay for workers who are paid into Social Security. The other are for those who are adult disabled child beneficiaries, and I'll talk about that more in detail in a minute. And also we pay what's called the SSI, better known as a Supplemental Security Income Program. And now I want to say that that's paid out of the General Trust Fund, whereas the Social Security disability is paid out of the Social Security Trust Fund, and I'll talk about that in a second as well. Now, when it comes, I think I'm going forward or back here. Okay. Let's see here. It's kind of, all right. It was upside down. All right, okay. All right. Now, when it comes to disability, let me just say that our disability is unlike other agencies. Number one, we don't pay partial. Number 2, we don't pay temporary. And number 3, we don't pay based on percentages. Our definition is that a person must have a condition or an impairment that is expected to last at least 1 year or end in death, and you're not able to work. So you may very well be eligible with another agency or program, but not eligible for us because we have our own rules when it comes to Social Security disability. Now, let me also say that when it comes to our disability, you qualify yourself by working and paying into Social Security based on Social Security taxes. And so you must have a recent work history when you're filing for Social Security disability, a recent work history. Now, special rules do apply for younger persons because of obviously they need less work to qualify because of their age. And to give you an illustration with this, anyone that is under 24 years old, they must have worked at least a year and a half out of the 3-year period before their disability began. Anyone between the ages of 24 to 31 years old, they must have, since 21 years old, worked half of the time between 21 years old up to the time their disability began. They must have worked at least half of that time. And those who are 31 or older, they must have worked 5 out of the last 10 years before their disability began as far as the work history is concerned. So we're not just looking at, for Social Security disability, your disabling condition. We're also looking at your work history because this is paid out of the trust fund and it is based upon you working and paying into Social Security. Now, of course, the way we calculate your credits are based on your earnings. And for the year 2015, each $1,220 in earnings equals 1 credit. You can earn up to 4 credits per year. Normally, we need 40 credits over your lifetime or have worked and paid at least 10 years worth of work into Social Security to be insured for a benefit with our agency. But as I mentioned earlier, based upon your age, that could be a different factor, based on the age that you file for Social Security disability as far as the work history is concerned. Now, the benefits are calculated based upon your entire work history. So we don't use the last 5 years or the high 3 years. We look at your lifetime of earnings or your entire work history to calculate how your benefits are going to be paid to you. Now, there is a very good potential that you can receive both Social Security disability and SSI. SSI, as I'll mention in a few minutes, is based upon having limited income and resources. And for the year 2015, the maximum that a person can receive in SSI is $733 for an individual, $733 for an individual, and $1,100 for a couple. So $733 for an individual, $1,100 for a couple. However, if your Social Security disability is below that federal benefit rate I mentioned for SSI, you can very well receive both. So let's say hypothetically you're getting $700 from your Social Security disability. That means you could potentially receive $33 from SSI. So again, we're going to supplement the income up to the federal benefit rate for SSI. So keep that in mind. Some people are getting both SSI and Social Security because of the fact that their Social Security benefit based upon their work history is below that $733 that we can pay them both up to $733. Now, we can also pay dependents off of a disability record. We can pay a spouse off of a disabled record. And the criteria for a spouse to draw is the spouse must be at least age 62 years old. So if the spouse is at least age 62 years old, they can potentially draw off of a person getting disability. Let me make this point very clear. If the spouse waits until their full retirement age to file on that disabled record, the maximum we're going to pay a spouse on that disabled record is 50% or 1/2 of whatever the number holders do. Let me also make this point clear. Anytime you file a benefit with us before your full retirement age, expect to see a reduction in benefits. Expect to see a reduction that will not only affect you, but others that file on that record as well. So again, the spouse, if she's uninsured, and when I say uninsured, meaning she does not have 10 years or 40 quarters paid into Social Security, she can potentially start drawing as early as 62 off of that disabled record. However, if she's insured, she has 40 quarters or 10 years paid in, and she wants to engage us before her full retirement age, she must file on her record first. She must file the benefit on her record first, and then if there's anything that we can pay her on that record as a spouse, drawing off the disabled record, we can do so. We also can pay a spouse at any age if she's caring for her child in the house 16 years or younger. So if a spouse has a child 14 or 10 years old and the husband is disabled, she could potentially draw at 30, 35 years old until that child turns 16. Once the child turns 16, the spousal benefits will stop for the spouse, but continue on for the child who is also eligible, because we also pay children on a disabled record up to age 18 or 19 if they're still in high school. We used to pay up to age 22, but that law changed back in 1984. So it's now age 18 or 19 if they're still in high school that we can potentially pay a child on a disabled record. We can also pay divorced spouses. Divorced spouses can also draw on a disabled record. Now, the criteria for a divorced spouse to draw is the divorced spouse must be at least age 62, been married to the ex-spouse for at least 10 years, and not currently married. So if there's a divorced spouse at least age 62, married to the ex-spouse for at least 10 years and not currently married, they can potentially draw on that person's disabled record. We also, going further, pay adult disabled children, as I mentioned earlier. Now, the criteria for an adult disabled child to draw is the adult disabled child must have been diagnosed with a condition before age 22, not currently married, and have a parent drawing disability, retirement, or even deceased benefits. Let me give you an example. So let's say we're dealing with MS. Let's say I developed MS at 15 years old, and I'm now 37 with that condition. I'm not married, but I have a parent that's either disabled and getting disability from Social Security or retired. I, the adult 37-year-old son, am eligible, in this case, to draw off my parent's record who's getting disability or retirement because I met the criteria. I became disabled before age 22. I'm not currently married, and I have a parent drawing either disability or retirement. So we pay adult disabled children in this instance. Now, let me just mention that those who file for Social Security disability and are approved, you receive Medicare, but you receive Medicare after 24 months or 2 years of being on disability. So you can receive Medicare before 65 if you're disabled, but it takes 2 years for that to kick in. And also, let me mention also the other criteria. If you are under 65 years old, you can also get Medicare if you have Lou Gehrig's disease, better known as ALS. You can also get Medicare if you have permanent kidney failure and on dialysis. So in those three instances, before you turn 65, which is normally the age you must be before Medicare kicks in for you, you can get Medicare before 65 if you're disabled with Social Security and have been so for at least 2 years or 24 months. Again, have Lou Gehrig's disease or ALS. Now, I'll be honest with you. A lot of people are saying, well, that's too long to have Medicare, to wait for Medicare. Well, I would say in this case, or I would advise that you may want to look into the Affordable Care Act at this point while you're waiting for your Medicare to start, so that you can have at least coverage until your Medicare kicks in. So this is an option that you would look at the Obamacare or whatever you want to call it, Affordable Care Act, to see if they can cover you for your health insurance until your Medicare kicks in. We also pay, like I mentioned earlier, SSI, better known as the Supplemental Security Income. That's paid out of the General Trust Fund. In other words, you don't have to have a work history to qualify for SSI, but you do have to have limited income and resources. So basically, you can be blind at any age, or disabled at any age, or if you're 65 years or older, that can qualify you potentially for the SSI program. But again, remember, you must have limited income and resources. Now, when we talk about resources, a person can only have resources as an individual for this program of up to $2,000. And for a couple, $3,000. What we count are things like your bank account, a second car, stocks, bonds, mutual funds, liquid assets or property other than where you stay. We don't count the property where you stay, but other than where you stay. This adds up to that resource limit that you're allowed to have for SSI. What we do not count is, of course, the home you live in. We don't count the first car you have. We don't count burial plots. We don't count some other resources set aside, like, for your burial, such as the cash value of your policy. Now, when it comes to SSI, you also get a health insurance called Medicaid. And there's a difference between Medicaid and Medicare. Medicare is a federal health insurance that can be used anywhere in the country. Medicaid is a state health insurance that's only good for the state that you're living in. So if you're in Alabama and have Alabama Medicaid, it will not work in Tennessee or vice versa. But again, if you're receiving SSI, Medicaid comes automatically with SSI. So when you get SSI, you have Medicaid automatically. Now, as far as the application process, because the question is, well, how do I apply? You can apply one of three ways. You can go to our website, which is www.socialsecurity.gov, and click on disability, and it'll take you through filing the application process. Or you can call your local office to have an in-office or a telephone appointment. In-office is where you're seeing someone face-to-face. Telephone is where they're calling you and doing everything over the phone with you. That's another option. Or, of course, you can call the toll-free number at our toll-free number, which is 1-800-772-1213. By the way, those lines are open from 7 a.m. to 7 p.m. Monday through Friday. But those are the three ways you can file for disability. If you decide to do it on our website, you'll be taken to our link that says disability, and it'll basically walk you through the application process. And the wonderful thing about filing online is that you can complete this at your own convenience. You know, many times if you're coming into the office or doing it on the phone, you're having to give us everything in one session. Whereas filing online, you can start, and if you don't have all the information, you can stop and come back later. And we give you a certain number to get back online to complete your process. So you can start and stop as many times as you want, and it's based upon your convenience of filing the application online. Taking advantage of our online help that's available for you, and also you can print a copy of the application for your records before you submit them. So again, these are all the benefits you have by filing the application online with us. And of course, what happens, it's sent electronically to the local office, and they'll look over the application. They'll only call you back if there are discrepancies. But if there's no discrepancies, we will send it up based upon what I'm about to tell you now. So you're filing for Social Security disability. What do you need to have? All we're going to ask from you are the names, addresses, and telephone numbers of doctors you've gone to, tests you've had, and medicines you're taking. We will get the medical records ourselves. So don't worry about sending to us any medical records. We will get all of that ourselves. All we ask from you is just the names, addresses, and telephone numbers of these entities. We will contact them, and we send them up to what's called a disability determination service. And for Alabama, that's in Birmingham. Those set of doctors will look at our criteria for disability to see if you meet those criteria, and of course make a decision. Now, it takes normally 3 to 6 months, 3 to 6 months for a decision to be made. So if you feel that you're disabled, I recommend that you file as soon as you feel that you're disabled, because again, it's going to take 3 to 6 months for us to make a medical decision on your disability. Now, if you are approved, of course, you'll be getting a letter, and of course, your benefits will start based upon, the diagnosis, based upon the program you filed for. Let me mention this point. If you receive SSI, we pay you back to the time of your protective filing, as far as when you filed the application, and up to the time that you're now getting the notification. If you're approved for Social Security disability, you're going to get your award, but there's a 5-month waiting period. There's a 5-month waiting period before your actual benefits start. So if I'm approved, let's say in August, there's going to be a 5-month waiting period that I'm going to have to go through before I receive my first check. It's sort of like if you look at long-term health insurance, long-term disability insurance rather, they have like a 90-day period or a 180-day period. It's sort of like that same scenario. Now, please don't look at me like I made the law. Congress made the law. So you can go to them if you have any issues with that. All right? But if you are denied, just keep this in mind. You have appeals rights. You have 60 days to file an appeal on any denial you receive from Social Security. 60 days to keep that case active. Now, you can file actually on our website by applying, just like you apply for disability online, you can file for your appeal online as well by going to our website, socialsecurity.gov/appeal/disability/appeal. You will complete the forms. There's a denial letter that will be sent to you. And in that denial letter will be a link to the actual forms you need to file online when you do so. So you go to that denial letter and get that link and apply that way. And also by filling out an appeal disability report. Now, when you're filing an appeal, what happens is we send your case up to a judge, an administrative law judge. And those judges are the ones that will look at our decision to see if we made the right decision, or they can reverse the decision. Now, it could potentially take, and I'm just going to be frank with you, it can potentially take about up to, at this point, a year before you have a decision made by an administrative law judge. You go before an actual judge. You can, hire an attorney if you so desire, and of course, just plead your case before the judge, of course. So basically, in addition to filing for disability initially or filing an appeal, we're going to also ask for authorizations to receive from you to get, let me back up, an authorization that gives us permission to contact your medical sources. So they are requiring that before they release any information to us, there's a signed release from you. So expect to have to sign a release to get that information, released by your health providers to us. As I'm bringing this to a close, let me mention a couple of things. We are trying to improve our process. I mentioned earlier that it normally takes 3 to 6 months to make a decision, but there's what we have an initiative called the Quick Disability Determination, or QDD. This is when you are telling us about your disabling condition, we're going to look at certain wordings and certain phrases of words you use to describe your disability. And if it's such that it brings a red flag that this is a pretty severe case, we can expedite your case for a decision. So in other words, by you telling us and describing in detail what your condition is, we can potentially expedite your case to have a quicker decision made under the QDD initiative. The other is called the compassionate allowances. Now, this is where there's 200 either cancers and or diseases that we have listed on our website, that if you allege one of those diseases, we can have a decision made for you in 10 to 12 days instead of 3 to 6 months. 10 to 12 days. You can go to our website, socialsecurity.gov/compassionate allowances. All the different diseases and or cancers are listed there, that if one of those are the ones that you're alleging, we can have a decision made for you in 10 to 12 days, as opposed to 3 to 6 months regarding your disability. Now, I talked with some of you at the table before you came in and out. By the way, I have a lot of pamphlets out there on the table that deals with disability. But one thing I mentioned was the fact that you can now, and this is for everyone, whether you're disabled or not, create a My Social Security account. A My Social Security account. And what this does, this gives you the ability to create an account to do business with us without having to come into the office or set up an appointment. The wonderful thing about this is the fact, well, first of all, you must be at least age 18, have a valid email address, U.S. mailing address, and obviously a Social Security number. So this means that even your children or grandchildren, I would really encourage to create a My Social Security account. So if they're just starting off working in their work history, they can create this account to download their Social Security statement. If you notice, we stopped sending those statements out on an annual basis because of budgetary concerns. We are now resuming sending those out, but only in 5-year increments until you turn 60 years old. But you can now create an account and download this statement at any time. And the wonderful thing about this, you want to do that because you want to make sure that all of your earnings are correct on this statement. You can also use this statement as a financial tool to plan for your retirement if you're not yet there, because you can get an estimate of what your retirement would look like, or an estimate about disability, or an estimate about survivor benefits as well. If you're already drawing benefits, the advantage of having a My Social Security account is that you can now download your proof of income letter, start a stop direct deposit, change your address, or you can also get a replacement Medicare card or a replacement 1099 for tax purposes. So all of these things you can do by creating a My Social Security account. As I mentioned earlier, the benefit of benefit verification helps out when you're applying for loans or things of that nature. So again, this is one of the benefits of creating this account. Now, we do understand privacy, and we understand that identity theft is one of the fastest growing crimes in the U.S. at this moment. So with that being said, we have partnered with a private authentication service provider called Experian to make sure you are who you are when you're signing up for this account. So with that being said, you're going to be asked certain questions by Social Security that are not normally asked to make sure you're the right person. Questions such as to give us the last 8 digits of your credit card number, or the first loan on your first house, or maybe information over your W-2 form, Do not be afraid or offended by these questions as long as they're on our website. But we must ask these questions of you to authenticate you're the right person as you're signing up for this particular account. So for more information about disability, of course, you can visit our website, again, socialsecurity.gov. And there's a myriad of pamphlets and information you can download on our website. Of course, disability benefits, SSI, and also even benefits for children, or even just have a dialogue. We have the Faces of Disability on there as well, where you can hear live stories from various ones that have various types of issues or conditions with their health. Again, our website, socialsecurity.gov, or our toll-free number, 1-800-772-1213. Or if you're a people watcher, come inside the office, have a seat, and we'll call you eventually. And I'm very serious. But if you want to avoid that drama or that trauma, hint, call us first and set up an appointment so you're being seen at a specific time as opposed to being a walk-in. Now, if you don't mind babies crawling on you and hearing all kind of stories all day, come on in. But if you want to be seen at a specific time, hint, call us first and set up an appointment so you're being seen at a specific time to give you the service that you need. At this point, I'm going to stop and open up for any questions anyone may have.
Thank you. Anybody have questions? Okay, over here.
Yes, ma'am.
Okay, suppose I miss my 60-day appeal and I go beyond that period, what happens?
Okay, repeat your question again, please.
If I am denied disability and I have that 60-day appeal period, suppose I go beyond that 60-day appeal period, what happens?
Her question is, if she goes beyond 60 days after being denied, what happens? You forfeit that case and have to start the whole process over again. So if you go beyond 60 days, you're forfeiting that whole case and you must start the whole process over again for a new decision. Any other questions?
Everybody know it all about Social Security? Okay, see? Wait. You got to remember. Oh.
If you're on Social Security, does Social Security ever reevaluate that or
Okay.
that
Her
disability?
question is dealing with Social Security disability. And do we ever do medical reviews to see if you will continue to receive our benefits? And the answer is yes. We do medical reviews once every 3 years, 5 years, or 7 years. So just because you're on disability does not mean you're going to be on there for the rest of your life. We do medical reviews. They're done randomly. So again, it's based upon whenever they choose your case to come up for review. Okay.
Any other questions? I have a question.
Yes.
Did you speak about SSA? Did you speak about SSI?
Okay, yes, I did.
You did? Okay. Does anybody have any questions about SSI? Nobody? Okay, then I'm sorry.
Okay.
Okay.
Well, I want to thank you all for your time. You've been a wonderful audience, and have a good night.
Thank you.
A lot of information has been passed out tonight, Dr. Reiser, Mr. McKinney. And if you get home and you think, what did he say or what did she say? Remember, you can always go to the website, go to the YouTube channel. It'll take a couple of days, 2 or 3 days for Bill to get it loaded up. But you can always review this program and any of the other programs that's on there.
And again, thank you for coming. Everybody drive safe going home. Thank you. And I have to again thank those that gave us the funding to do tonight's program, Genzyme, a Sanofi company.